All right. So welcome everyone. This is the Measuring Change using Bree collaborative guidelines and metrics to inform provider-facing opioid dashboards. We will be reviewing a little bit about the Bree collaborative briefly before we get started with our presentation. Our presenter today is Bethany Enriquez. She is the Quality Improvement Nurse Consultant for Quality and Patient Safety at Optum. And she's going to be presenting on how Optum has leveraged the Bree collaborative reports to support their implementation of their provider-facing opioid prescribing dashboards. We will have, as I said, a 5-minute Q&A at the end, and then a little bit at the closing. Just a brief overview of the Bree Collaborative. We were established by legislative statute in 2011, and the collaborative members are appointed by the governor. So we bring together organizations from all across Washington state to write guidelines on topics where there's a lot of variation in care or waste and cost overruns, or things are just kind of unknown about that topic, and the groups come together and write recommendations for best practices. The Bree then submits our reports to the HCA, and they implement them into their MCO contracts. But other audiences are also able to implement our guidelines, and this little box here to the right is kind of how our guidelines flow through the healthcare ecosystem in Washington state. Nope. And that is my introduction about the Bree Collaborative. So I would like to introduce Bethany Enriquez. She is going to present on their implementation of our opioid prescribing metrics and our opioid prescribing guidelines. So Bethany, go ahead.
Hello, everyone. Before I start sharing a slide deck, I wanted to introduce myself, and my name is Bethany Enriquez. I'm with Optum Washington. So it's nice to meet you. I wanted to, like I said, show my face because I'm going to go off camera to present to you all. And please put any questions in the chat, but know that we're likely not going to address them until after the presentation's over, and we'll certainly give you time. And if there's nothing that I can answer for you today, I am resourceful at the very least, and I will make sure to get you an answer, if not by email too. So I'm going to be going off of camera just 1 second to share my slide deck. So again, welcome everybody. My name is Bethany Enriquez, and I'm a quality improvement nurse consultant for Optum Washington. I want to first thank you all for attending this webinar today, where I'm going to be representing Optum Washington Employed Group and presenting about the evolution of our chronic opioid therapy program, but more specifically about how our program's evolution of where it started to where we are today. And that includes incorporating the Bree collaborative metrics into our program. My goal today is to share with you how we at Optum Washington have successfully implemented our program, but also specifically how it's integrated Bree collaborative metrics into our reporting specifications to improve our opioid prescribing practices. It's important for you all to know that by leveraging provider-facing dashboards and data-driven metrics, our COT program has enhanced transparency for our providers, monitoring patient safety risks, and it assists them in holding providers accountable for their prescribing behaviors. So again, my intention today is to highlight the development of our program, the collaborative infrastructure behind it, and the measurable outcomes we've achieved through education, reporting, and continuous quality improvement. And for you all today, just to know a little bit more about me as we deep dive into this topic, I came on at Optum in May of 2023, and I've been leading the COT program since around July of 2023. And prior to joining at Optum Washington, I've been a nurse for 22 years, and I've specialized in critical care medicine at the bedside for about 13 of those years. I also had some experience in nurse management and critical care, and then transitioned to quality improvement consultancy, mostly in medical sales. And then I had transitioned to being a service line manager at Fred Hutchinson Cancer Center specifically the pain clinic before I came on at Optum Washington to take over the COT program. So that really has helped me with a seamless transition. So in order to understand our program, it's important to understand the timeline of our program and how it's evolved. And prior to 2012, I think a lot of you on the call may know that the opioid crisis in this nation and worldwide has been escalating due to overprescribing and inconsistent pain management practices. In response to that, there were new regulations that were introduced really to curb opioid misuse, including things that affected us in the state of Washington, the 2007 AMDG, Washington State Agency Medical Directors Group Opioid Prescribing Guidelines. There was then in 2010 also a Washington State House Bill 2876 that helped us improve prescribing standards. And then the big whammy came in 2016 with the CDC guidelines for opioid prescribing, which were updated in 2022 as well. But one of the things that affected us primarily within Optum Washington, and prior to it becoming Optum Washington, which was when we were the Everett Clinic in 2017, were the Dr. Robert Bree Collaborative Opioid Prescribing Metrics. However, back in 2012, the Everett Clinic, in recognition of the growing crisis in opiates, launched an initiative to improve opioid prescribing practices. Some of the key actions that the Everett Clinic included at that time were developing policies related to opioid prescribing and the creation of smart tools within our Epic electronic health record system. Then really what was focused on was educating providers on those policies, on opioid safety, and those newly developed policies and tools and how to acclimate to them. In 2016, that's when formally the Everett Clinic established the chronic opioid therapy program that we have as today. And its focus today, even in 2016 and now to today, is on safe and appropriate pain management for patients, managing those at high risk, and monitoring the patient and the provider's adherence to prescribing policies, guidelines, and that are specific to Washington state and federal requirements. During this time period in 2016, this is when we started developing reporting tools to track the program's progress. These tools started then, and they eventually evolved into what later became, and I'm going to talk about later, what is now our COT Power BI dashboard. From the years of 2016 to 2020, this was a time period of refinement in our program and the expansion for our program, where we focused on tweaking and continuous improvement of our reporting, and that was to help to meet provider and clinic needs. It was also a time where we focused on the creation and integration of specific metrics to track opioid prescribing. And during this time, we also started to adjust our workflows for better implementation in clinical practice for our providers. 2020 to 2021 was a monumental time period for the Everett Clinic. This is when they merged with the Poly Clinic to become part of Optum Washington Employed Group. This integration led to the creation of a couple things for our COT program. One that was very specific was an opioid operations committee that was to meet monthly and still does to help to oversee the COT program. It also helped that we had now more tools and facets to explore new reporting systems to better align with Optum Washington's broader goals. And from 2023 until now, this is when we have really enhanced the tools that we've had and focused on education. In July of 2023, this is when we launched our Power BI COT dashboard, and it became and has become a key tool, allowing our providers to track their opioid prescribing practices in real time to identify areas for remediation and improvement. So in summary, our COT program has evolved from a simple initiative into what is now a comprehensive, robust, data-driven program that continues to grow and adapt in response to the opioid crisis. But also, it's important to note that our program's focus has always really remained on improving patient safety around opiate prescribing, while also enhancing provider knowledge, support, and ease of use of those data reports that we have by continuously refining the tools and processes for them to have better outcomes with patients. Some of the things, though, we have that have helped to build our program's stability and success should be mentioned. And many of the factors that have contributed to that success are related to collaboration, education and feedback, and the enhancement of our reporting. When it comes to collaboration, we talked earlier about how we formulated an opioid operations committee in 2020 to 2021. Well, the formation of that opioid operations committee has been a pivotal factor in our program's success. This monthly meeting serves as a central forum for developing and refining policies, guidelines, and dashboard metrics related to our opioid prescribing and controlled substance prescribing. The committee really includes representatives from multiple disciplines, including provider leadership, that's from both sides, the Everett Clinic and the Polyclinic together, quality leadership in clinical pharmacy, Epic and data analytics teams, clinical education and specialty groups, including our comprehensive pain clinic, practice management, which can include medical assistants and registered nurses, and ad hoc representatives from urgent care and float departments. Our opioid operations committee also collaborates very closely with our regional guideline committee, and that's to ensure alignment with our regional prescribing standards and to gather feedback for continuous improvement to our program. I'd be remiss not to mention the collaboration that has existed and continues to exist between our opioid operations committee and our regional guideline committee. It has been critical, as I mentioned. And what that has helped is to ensure that our policies and guidelines are consistent with regional standards and feasible within our EPIC system functionality. For example, the collaboration in the past year between these two committees resulted in our collective ability to refine guidelines that are specific for acute versus chronic benzodiazepine prescribing, which also led us to help in the creation of a separate chronic benzodiazepine sedative contract from a standalone stimulant contract. All of this is to say it helped in addressing gaps in our previous non-specific controlled substance agreements. Again, speaking of collaboration, we have established with our COT program weekly meetings with our EPIC and data analytic counterpart teams, and that's been essential for refining our COT program's reporting tools. The sessions that we have with them help to provide a platform for identifying glitches to our dashboard, helps to enhance the tools that we use in EPIC, and explore new creative ideas to help our providers. For instance, with the collaboration between these two EPIC team, the EPIC team and the data analytic team, it helped in the creation of what we call a BPA, and this is a best practice advisory that exists in our EPIC electronic health record. That's a stop for one of our metrics for prescription monitoring program. And this is a check that the providers do in safety of how they prescribe opiates. It also helped in the development of another BPA that we've developed surrounding Narcan prescribing that's been integral to our COT metrics as well. The strong partnership that we have within the COT program with the data and analytics and EPIC analytics teams has really been instrumental in transforming our reporting from very basic systems of reporting in 2016 to the much more advanced Power BI COT dashboard that we use today. Another pillar to the COT program success has been education and feedback. With robust education and being open to feedback within our program, it's helped to ensure that our providers understand the COT program's guidelines, the tools we have for them to use, and the metrics that they're getting measured on, and specifically to have a voice in how we can make our program more intuitive and user-friendly for them. The education that we've provided and the feedback that we get from it has been achieved through on-site and online resource training, and that's to support ongoing learning during new provider orientation, because this helps us to establish a very strong foundation for new staff in the program from initiation in their position at Optum Washington. And also, this education and feedback has been achieved through attendance from our perspective with the COT program to quarterly leadership meetings within Optum Washington. This is where we specifically share updates and feedback with senior leadership to build broader support for the program in totality. Our education sessions with each clinic and with providers also serve as a forum for providers to give us feedback on what works well for them and what needs improvement and refinement. This continuous feedback loop really has helped to refine our program, keeping it easy to navigate and responsive to the provider's needs. And we view feedback very regularly by the Opioid Operations Committee and by the EPIC and Data Analytics team to help to drive further enhancements to our EPIC tools and to our reporting. Lastly, a critical piece of the COT program success can be attributed to effective communication. Initially, when the program started, communication was pretty informal, mostly email, but has evolved into a more structured approach. We now have, like I said, regular opioid operation committee meetings. Those happen monthly. We have clinic-wide education, both on-site and virtual, and that's to communicate updates on policies, guidelines, metrics, and any changes to the EPIC tools or the reporting that we have for COT. And we also participate in new provider orientation videos. And we have refresher courses on COT, and that's to ensure that there's ongoing education on the topic. The enhancement of our reporting has truly, though, been a key driver of our program's success. By providing real-time actionable feedback through our COT dashboard, providers can then adjust their practices and improve patient safety and opioid prescribing. Our enhanced reporting has allowed us to track progress, identify areas for improvement, and really assure that adherence to best practices are happening. But to fully grasp our program is to know how much our reporting has really evolved over time. Well, we started doing basic reporting in 2016. And from 2016 to July of 2023, at that period of time, regional and site leadership, this would include physicians, practice managers, mostly at the Everett Clinic until 2021, when the Polyclinic was integrated into Optum Washington, received monthly reports on COT. And this was based upon 7 core metrics that were developed to align with the CDC and Washington State opioid prescribing guidelines. I'm going to mention the following 7 metrics that we designed. And these, like I said, were designed to monitor and improve our COT practices. The providers are measured on an agreement metric, meaning that they have a signed COT agreement with the patient that's completed annually, that they have an urine testing metric, and this means that they have completed a urine drug tox screen. It can be completed either through a urine, a blood serum, or an oral fluid, and it needs to be conducted at least once a year to meet the metric. They have an opioid risk tool score metric, and this is qualified by a provider scoring the patient on an ORT that's integrated into our Epic electronic health record, and it needs to be completed at the start of the patient's chronic opioid therapy. There's also the metric that we have for pain, where the provider scores the patient's level of pain from the patient from a 0 to 10, and it's scored at least once per year to meet the metric. We have a pain interference score metric, and that is how the patient rates their pain and how it affects their daily activities, and that needs to be completed annually to meet the metric. And we also have the PMP review. I mentioned this before. This is a prescription monitoring program metric, and it's met by them marking consistent or not consistent. And this is done by, like I said, the Best Practice Advisory BPA. And I'm very happy to report that we are generally at 100% compliance with that metric in particular because of the BPA. And we also have, lastly, our morphine equivalent dose calculation metric. This is done by the provider scoring the MED within the Epic electronic health record by an integrated opioid dose calculator that we have. It needs to be done upon initiation of COT and with any dose adjustments. So this was reported out to physician leadership in 2016, as well as practice leadership, and they were educated on these 7 metrics. They were also educated on how they can be met during visits with patients qualifying as COT, and also education was provided about what qualified patients being designated COT, so that they could understand the reports that were coming to them. And as you can see on the slide, our reporting criteria has changed quite a bit from what it was in 2016 to what it is now at from 2023 on in the present. At the time in 2016, when reporting was originally launched, COT patients were qualified and identified using a 6-month look back, focusing on key factors of the COT qualifiers being that they were those patients receiving 3 or more opioid prescriptions, and those patients would then qualify to the majority prescriber at the clinic assigned to each patient. These reports were then shared with regional and site leadership to raise awareness and improve compliance, and the reports were typically provided with a 1-month delay. It's interesting because I have told people, and I discussed this with a confidant recently, that our reporting back in 2016 used to be like a windshield that's covered in rain. And once a month, the windshield wipers would clean it off and you'd see, right? But we understand as time went on that that's a lag period of time and it needed to be improved. So now I think about what our reporting has come to in 2020, July of 2023 and on with our Power BI dashboard as a windshield that's constantly filled with rain, but the wipers are going all the time, right? So that the physicians can see clearly what is going on every day, day to day with their patient population that's paneling to them. And that's been affected specifically in 2017 because of new guidelines from the Bree Opioid Collaborative and the Washington State House Bill 1427. These both called for our program as like a red flag to incorporate much more precise definitions and methods for identifying and qualifying our COT patients, as well as how we were assigning them to providers. So key updates that we implemented to our COT program that were decidedly included from the Bree collaborative metrics were a much more enhanced COT definition that you can see to the right. We now, per July of 2023, since we launched our Power BI COT dashboard, we now look at patients from a 90-day look back period. And we also have inclusion of information on patients that are concomitantly prescribed benzodiazepines and sedative medications. And the qualifiers that we use for this 90-day look back are patients that are either prescribed greater than or equal to 56 days of opioid supply or greater than 84 tabs or capsules of opiates supplied in the past 90 days. Also, we enhanced it for our provider assignment and clarified that COT patients should now be assigned to their primary authorizing provider, AKA the provider that has signed their COT agreement or their most recent prescriber. So a lot of enhancements happened specifically related to the Bree collaborative metrics that we incorporated. I'm so sorry I skipped ahead and I didn't mean to do that. I think that the most important thing to know is that the incorporation of these more enhanced and specific definitions helped to provide more granularity to our providers and then in turn required more real-time reporting. This really prompted our program's collaboration with the Epic analytics and data analytics team that we have to improve our reporting capabilities. So from the time period of 2017 to 2023, with input from our Opioid Operations Committee, our Regional Guideline Committee, provider leadership, the data and Epic analytics team, we were able to enhance our reporting tools. And the result was the development of our Power BI dashboard, which now pulls data directly from Epic day to day. It provides clinicians with real-time feedback on compliance with their 7 core metrics, and it offers a comprehensive view of their COT performance and enables them to have timely interventions to promote safer opioid prescribing practices. Our dashboard launch in July of 2023 really incorporated enhancements to our reporting based upon those Bree collaborative metrics. And that has done us a world of good and marked a significant improvement in monitoring and supporting the goals that we've had towards safer opioid prescribing. And as you can see from the slide, I'm going to show you an actual snippet from our dashboard on the next slide. We've had a lot of improvement and it still grows month to month. So like I said, the COT dashboard was officially launched in July of 2023. And you're seeing a snippet of it right now. And as you can see on the right corner where it says updated date, you're seeing our metrics as of June the 17th of 2025. It's really been a key tool for us in improving our compliance with our 7 core metrics. However, to ensure its effective use, communication and education were rolled out regionally and site by site with both virtual and in-person training for our providers to understand how to interpret the dashboard and how to meet each individual metric within the Epic electronic health record. And I can say as of April of 2024, all primary care sites and specialty sites across the Everett Clinic and the Polyclinic have received training. Refresher education continues regularly, and that's based upon monthly clinic and provider performance, and that's to help ensure that the program remains aligned with best practices. Additionally, our dashboard undergoes random validation on a day-to-day and a week-to-week basis, and it's mostly to ensure data accuracy and operational efficiency and validity. Some key features to talk about and to make our dashboard shine is to show you that it offers a comprehensive view of overall compliance within our 7 COT metrics that we're measuring across the entire Optum Washington employee group, meaning all of the Everett Clinic and all of the Polyclinic sites. I have a sample up on the slide, and what it's showing you, and it's highlighting compliance across service lines and individual metrics. Some things to catch your eye are to show you the compliance by service line. We have the ability to do that with our dashboard. So the metrics are displayed for each service line, each individual metric, and overall compliance. We also have dynamic data that I cannot show you on the slide where we can drill down, right? The dashboard can drill down to show data by provider, by clinic, by patient, and by MRN for each individual metric. And beyond the core measures, those core 7 measures, we do also have additional insights that our dashboard displays to providers. One of them being the actual MED score that the patient has if it's greater than 50. And that's to help providers identify patients who may require further consultation with comprehensive pain. We also have some columns in there that help providers to identify and if patients are concomitantly prescribed benzodiazepines and or sedatives. And we also have an integrated column once you drill down a provider's panel to see if a patient's been concurrently prescribed Narcan. So there's a lot more data than what you can see necessarily in this slide that we can drill down to provide to providers. The target of compliance that we have asked for our clinics and our providers is set at greater than 75%. That's with the expectation that each provider achieves greater than 75% compliance per metric, and that each standalone clinic maintains greater than 75% overall compliance in overall COT metrics in totality. And as you can see on this slide, we are, for all of Optum Washington, above our goal of greater than 75% compliance. And we're still continuously making improvement month to month. I would tell you confidently the keys to our improvement have been ongoing education, collaboration, communication, but specifically specificity and transparency of our metrics. This is all to say the chronic opioid therapy program has come a long way at Optum Washington. And while significant strides have been made, our work is far from finished, and we know that. Each improvement and enhancement that we've made contributes and has contributed to a larger goal, which has been saving lives in the fight against the opioid epidemic. We have had some key milestones and developments to mention along the way. One thing to note is that after the 2020 integration collaboration of the Everett Clinic and the Polyclinic into Optum Washington, it became clear that our COT policies, contracts, and guidelines needed to be unified across both organizations for consistency and patient safety. So key steps on that journey have included us regionalizing our chronic opioid policy in October of 2023 and regionalizing a COT agreement for all clinics by April of 2024. This also included us recognizing the need for a separation of our benzodiazepine and sedative agreement from our stimulant agreement. These were finalized, separated, and integrated into our electronic health record by October of 2024. And also, this journey has included us understanding that we needed much more site-specific education and metric improvement along the way. This has happened with education specifically, right? Education on the COT program and the COT dashboard was completed for all of the Everett Clinic sites and all the Polyclinic sites by April of 2024. But ongoing COT refresher education is being focused all the time on clinics when their compliance levels drop below 75%. We consider this refresher education, and this includes hands-on EPIC training in a playground EPIC environment. And it's also included the development of standard of work documents that we provide to clinicians and site managers that help to guide clinical staff in improving COT metric compliance during their actual visits. Another key area for our COT program's future development and a goal of ours is the creation of a self-sustaining medication-assisted treatment program. Progress that we've made on that includes the launch in December of 2023 of a MOUD, Medication for Opioid Use Disorder Policy Development Committee. That development committee merged in July of 2024 with our Opioid Operations Committee, just for more robust collaboration and attendance. And the synergy of both of those working together have helped in the development of an MOUD policy and treatment agreement. And we are very, very close to launching these both in the fall here of 2025. One thing that's very important to mention about our program too is surrounding our metric compliance. Like I said, specifically where we are now with our metric compliance, our overall goal, like I said, for Optum Washington Employed Group has been to achieve greater than 75% overall compliance with COT metrics. You saw on the previous slide a snippet from June the 17th where it said our compliance was at 79.1. We're actually at 79.5 today. So we are still rocking and climbing with each month, and our ongoing efforts are remaining laser focused on targeted one-on-one education for clinics with compliance below 75% and any one-on-one remediation education that a provider might need that's having specific continued deficits in their metric compliance. So to wrap up, I would like to mention that our chronic opioid therapy program within Optum Washington remains a critical initiative in combating the opioid crisis and ensuring safer, more effective pain management through measured metrics and transparency of those metrics with our providers for continuous feedback and improvement. Optum Washington has set a compliance goal, like I said, of 75% for COT metrics which we have achieved our target goal, a target that represents lives saved and a significant reduction in opioid-related risks. However, the ultimate goal for us is to achieve 100% metric compliance for every patient every single time. This means ensuring that all clinical practices, protocols, and tools that we have consistently align with best practices for opioid prescribing and patient safety. So as you can all imagine, this is a moving target that we're tirelessly chasing for perfection, undeterred every day. To reach this level of compliance, we're staying steadfast focused on refining our Epic tools, policies, and processes to make it easier and more user-friendly focused for our providers to meet those metrics with each patient, each visit. Streamlining workflows to us is very important, and enhancing the provider using experience in our electronic health record is a strong focus for us. And we're confident that this will support our providers in delivering the safest care while maintaining the highest standards of practice and opioid safety. I would be remiss not to mention some of the things that we're currently working on to enhance the dashboard that we already have in the chase of enhancing the provider user experience. We have a long-term project that's going on right now to incorporate the Power BI dashboard that we have to integrate it specifically into Epic and then exist solely in Epic so that the providers don't have to leave Epic to check the dashboard, that they can do that. We're still in the build of that, and so our hope is to have that launched here soon. And we're also working on other enhancements to our dashboard related to MOUD prescribing. We're working on adding some columns in the dashboard related to associated diagnoses of the med prescribed, and helping to make integrations in the build of the dashboard to help exclude COT metrics from patients that are prescribed buprenorphine, Suboxone, and their derivatives from any COT compliance metrics if it's used for medication for opioid use disorder. Also, notably, we are strongly focused on the development of a medication-assisted treatment program to address opioid use disorder. It is a key part of our strategy in the COT program, and it's a future focus to offer comprehensive care for our patients struggling with opioid addiction. Our goal for the COT program in totality within the next calendar year is to finalize and launch an MOUD policy and treatment agreement, which, like I said, we are scheduled to do in the fall. And that's with the intention of expanding that into a fully developed program, much like the COT program on its own. We believe that this expansion will help us to, quote unquote, close the circle by providing a full continuum of care for patients both before and after MOUD initiation. We do understand there is significant opportunity for growth for us within our program, particularly in the areas of social work care and addiction specialist support. And we also recognize that after the initiation of MOUD, patients will require increased structure in their care plans and more robust support services. This includes developing policies and frameworks for tapering, as well as strengthening the post-induction care structure to ensure long-term success. We also foresee the potential for future metrics, ones targeting and directed at MOUD, and even possibly the development of a dashboard to track MOUD-related outcomes to ensure consistent, high-quality care. We believe that this will further augment our ability to monitor patient progress and fine-tune the program for optimal results. So in closing, I really want to thank you all for giving me the opportunity to highlight our COT program, where it's grown in development, specificity, and infrastructure, and how we've improved our opioid prescribing practices through data-driven insights, collaboration, transparency, and shared accountability. Our guiding hope and focus has been to take vital steps towards safer, more transparent opioid prescribing practices to better benefit our patients. I hope you found this overview of our COT program's evolution from its inception to our future direction both informative and engaging, and I'd be happy to answer any questions you may have.
Thank you so much, Bethany. That was a wonderful presentation. I wanted to invite everybody now to ask questions. I see Gary already has his hand up, and I will, if you raise your hand, I'll allow you to talk. Gary, you can.
Yeah, hi. Can you hear me?
Yep, we can hear.
Yeah, that was a great talk. Thank you. Do you have any insight as to how you're doing with the post-operative opioid prescribing?
That's actually something that's integrated into our chronic management of opioid practice policy outside of specificities for COT. And so we're doing pretty well with that. And the best part is that I remember I was talking about in our program, one of the coolest parts, we have an opioid operations committee that meets monthly. And one of the leaders that attends it is from our comprehensive pain clinic. And she's always in direct connection with other specialty entities within our organization. So for example, we just last month reviewed our policy and took into consideration the things that we want to do with MOUD, brought it back to surgery and said, hey, are these in alignment with the patients that you're going to see pre-surgically, intrasurgically, and post-surgically with what we want to do with not only opiates, but also MOUD. So we're doing pretty well on that. And I think we have some growth to go, but I think the communication between our specialty entities is really what's helping that contain and survive and do pretty well.
Thank you.
You're welcome.
Thanks, Bethany. We have a question in the Q&A. One attendee asked, do any of your metrics flag any rapid or abrupt tapers or patient dismissals to follow up on how those patients are doing or to prevent this from happening?
We don't have any flags for that, but I will say that we do have flags that are integrated into some of our reports that are in Epic. So for example, we just worked on this recently, creating a tool called MedMatch for providers that when their patients provide urine drug screens, that I'm sure that some of you on this call may understand this, that sometimes our providers' inboxes will be flooded when they have a patient on COT and they send them for a urine tox screen and it comes back positive and they're like, oh no, what's going on? But what they're positive for is actually the medication they've been prescribed. And that creates, user fatigue for the providers, thinking that they have a bunch of their patients having disqualifying problems with what's coming up in their urine. So actually the MedMatch helps them to say, yes, it's positive for something you've prescribed, but if it's positive for something that you didn't, like an illicit substance, it will send an immediate trigger to the provider in their in-basket to alert them so that then they can change their prescribing practices. And that's all written within our policy and gives a lot of leverage to our providers to have taper and dismissal if urine tox screens or blood serums or oral fluid screens come back positive for illegal substances. But no, it is not integrated into the dashboard, but it's integrated into Epic. So it's kind of synonymous in one way.
Thank you. Feel free to raise your hand if you have other questions or type them into the Q&A or the chat box.
I would like to expound on that though, of what was mentioned, because I think that's somewhere where we want to go in the future, because like I said, one of the things we're working on now is how to integrate our Power BI dashboard into Epic so that the providers don't have to go outside of Epic to check their metrics. And so we have a lot of room to grow and a lot of creative bandwidth inside Epic to create flags like you're speaking of. And we've thought about that a lot. Like, what would be a flag that would stop you and say, hey, you really need to taper this patient? Would it be their urine? Would it be, that their pain functionality is not getting any better, right? Because we get that a lot where patients will come in and say that their activity of daily living is not improving or their function's not improving. They need more med, quote unquote, which we know the science behind that is very non-conclusive to say that it supports more opiate. So that's something we're really thinking about when it comes to Epic integrations.
Thanks, Bethany. Yeah, I think the same attendee had asked about if anyone is doing this. I think we can connect all of the attendees up if you guys would like to chat about that particular topic in a future event or a different forum. Bethany, I was wondering if you could talk a little bit about the kind of the specifics that the Bree metrics allowed you to get to in developing these dashboards. I know as we have talked, you've mentioned MME and
Yeah,
some other things. So.
Yeah, I think really what has helped us significantly, especially I would say the one really specific integrations we did based upon the Bree Collaborative was making it very specific about what qualifies a patient as COT. The two big qualifiers, right? Whether or not a patient in a 90-day look back is prescribed either greater than or equal to 56-day supply of opiates or greater than 84 tabs or capsules. That in and of itself has been a true gold standard for us of having to understand how a patient's qualified. But not only that, having a signed agreement so that when they panel to the provider, they're paneling to the correct provider. Because I think prior to not incorporating those and making those specifications, it made it a lot harder for providers to understand why all of the majority prescribers were getting all of the COT patients. They're like, well, I don't prescribe for this patient. And this is really hard for me to follow because then you're giving it to me, the majority prescriber, but then I have to tap my other, provider at my clinic to be like, hey, your metrics are not in tune, but it's coming to me. Those two specifics really helped. And it's helped so that providers really understand why, they need to have a patient on a yearly contract. Of course, you need to have them on a yearly contract because of everything that's contained in the contract. So the patient understands how to take their medication and that they're very clear on it. But it also helps so that they understand that then when you do that, that's going to make sure that the patient's paneled to the most appropriate provider, right? That doesn't mean we won't have instances. This is like life, nothing's perfect, where a patient might have an expired contract. And so the patient will then panel to somebody incorrectly. But because of that, it makes people more attuned to be like, oh, something's wrong. Can we investigate this? And when we investigate it, it only benefits the patient and the provider to be like, oh yeah, that's because your COT agreement's expired. Let's make sure to get one updated for the patient, right? Which is going to benefit the patient. So yeah, I think those have been probably the biggest things that have affected increased compliance, I would say.
And are there, besides the metrics that the Bree created, were there other guidelines on opioid prescribing that informed this dashboard development or this strategy for tracking patients?
For sure. A lot of the Washington State House bills and also CDC, the things they put out in 2016 and 2022. We're always looking at things within our program to make sure that our dashboard's in alignment with it. And we check our policies every 2 years for a review to make sure that we're in alignment. We actually just did something fairly recently where we were double checking our policies and whether or not that was going to help improve our dashboard based upon the Ryan Haight Act that came out and the updates in last year. Nothing had to change within our program because everything is set up appropriately, but we are constantly looking at these things. Actually, something just came up again last month about should we integrate something with the dashboard? There's been tramadol dosing increase changes, right? That it could affect MED scoring, and we were looking at that. So we are constantly keeping our ears open, constantly keeping our nose to the grindstone. And I think that is helpful in a collaborative effort because of whom attends our opioid operations committee meeting every month. I lead it, but there's a lot of providers on both the Everett Clinic and the Polyclinic side that come together synergistically to make sure, like, even if, hey, Bethany, you haven't heard of this, I heard this, can we make sure we follow up on this to keep us in tune so that the dashboard is remaining very relevant and very focused on requirements, right?
Another question has come in from David Mayo. How much time did it take for your EPIC team to optimize COT processes in the EHR? And how much time did it take to train the staff on the processes?
These are great questions. And I would tell you we're still not done. Like, I would tell you, though, that if you're asking from start to what we believe is finished to say that people are fully trained, probably about 1.5 years, 2 years. But EPIC is never really done. We have an EPIC internal team that not only monitors EPIC in the background and works on the build, which is the EPIC analytic team. They are constantly looking for ways in which we can improve and integrate things. So would I say it's ever done? No. But when it comes to the training on the dashboard, we started effectually at the beginning of 2023, even before the launch of the dashboard in July of 2023. And we were formally done in April of 2024. And as you can imagine, it's because maybe 1 month we're supposed to go to a clinic on site and it has to be rescheduled and moving parts. But I think the coolest thing is that anytime a clinic might be underperforming or a provider in particular is underperforming, there is never hesitation to reach out to me to help to provide refresher education. And we have also really benefited from changing how we've educated. I would say the education on not only our program, but our dashboard has changed much, much since I have come on at Optum. It was different when I first started, and then I've taken it and kind of made it my own. And I've myself wanted to be a sponge to say what's worked, what in the education needs to be better, so that people are absorbing the content and understanding where in Epic to meet their metrics, so that we can collect the metrics to protect them, right? So.
Right. I have a question about barriers between the two clinics. So, starting with the Everett Clinic and moving to Optum, were there different barriers for each clinic? And were there things that you leveraged either from the Bree or from other places that helped you get over those barriers?
I would say I would not be the person to talk about the barriers based upon the timing of when the Everett Clinic and the Polyclinic merged, because it happened before I came on. I would say also, understandably, the Polyclinic likely had more struggle when it came to understanding the program, because this is a program that the Polyclinic adopted because it was already functional at the Everett Clinic. That's not to say the Polyclinic didn't have some things going on with opioid therapy and chronic opioid therapy, but it wasn't as robust as what was going on at the Everett Clinic. So there was more of an adoption of that program to them. So that would have been a barrier. But I have to be honest, all of my Polyclinic colleagues have themselves been so instrumental in how our program continues to evolve, including the things we're doing now with MOUD. And speaking of that, and speaking in a bifurcation of the other part of your question, I would say it's been tantamount to our program and what we're doing right now and trying to do with MOUD. The resources that have helped us from the outside of our own CDO, CHC of Snohomish, they have been so helpful to us in how we've built the skeleton of our MOUD policy, because they're one of the only clinics that's similar to us in size and stature and how they run. And their leadership has been so gracious in sharing a lot of documents with us and how to build good policies that are going to benefit our patients with MOUD. So yeah, I hope that was a well-rounded answer for you. We've had so many resources given to us too. So I'm going to apologize already for not mentioning somebody that's probably helped us along the way.
Yeah, I will be very excited to see how your dashboards progress as you work toward having that kind of off-ramp for MOUD. It is something that Bree has just been working on in terms of revising our opioid use disorder treatment
Yeah,
report. And so that will be a very interesting part to follow along with you.
I agree. And I think that we're excited everything that we have at our fingertips for our Power BI COT dashboard of what that could mean for MOUD separately. I think that's exciting. And everybody would agree with you too on the Optum side that if we were able to do that with COT, what more could we do with MOUD too?
Yeah. Well, I wanted to start wrapping up here and add a few more things in terms of events and closing. But Bethany, I wanted to give you a chance before I do that if you have any other final comments or information that you wanted to share.
No, but I am going to put my email into the chat so that if anybody afterwards has any questions or, curiosities about our program, I'm absolutely happy to communicate with you. And if I don't ever have an answer, like I said earlier, I will find the resource to get you an answer as best I possibly can. But I hope you really all enjoyed the presentation on our program today. I think it's amazing, and I'm biased, of course, but
Great. Well, thank you very much. I'm going to share my screen here and share our slides again. Yeah. So I just wanted to remind you all that we'll have some other events coming up here in also around OUD. So the report that I mentioned on opioid use disorder treatment that we have revised, we're going to have an evaluation forum. And our evaluation forums are really where people can get together, chat more one-on-one, talk about the work that they're doing, and think about how they might collaborate, or how they might get help from the Bree or the foundation to plan out evaluations as they implement that report. I also wanted to encourage everybody, if you are looking for other reports or any of the opioid metrics or other guidelines on opioid prescribing, you can find them all on our Bree Collaborative website if you follow this QR code. And if so the Bethany and I have been working on a case study for this, so we will be sending out a one-pager summary of this work, and we will be later on having a write-up and hopefully a publication of this effort to improve transparency for providers in prescribing. In the meantime, you can keep up with other evaluation case studies and events or outcomes by following our blog. And if you're interested in contacting anybody, Bethany's email is here again, and our emails are down below at the Bree. So thank you all again for joining us in our webinar, and stop sharing here. We hope to see you at different events as the year continues. We will be having one more. Oh, I see somebody else has, before we go, we have one other person with a raised hand. Just one second. Shirley, if you'd like to ask your question. You should be able to unmute yourself. Shirley, if you would like to contact me, I would be happy. If you still have your question later on, I'd be happy to answer it for you. So thank you all again. I appreciate your time in attending our webinar, and we look forward to seeing you again at our next Measuring Change webinar in the fall. Thank you.